today, in the next sort of 45 minutes, leaving some time for conversation at the end, is to leave you with an understanding of opioid use disorder as a chronic but very treatable medical illness, to describe what effective treatment for opioid use disorder looks like, and then to give you an example of how a healthcare system, in this case Mass General, can really rethink how we take care of patients with substance use disorders to make sure that they're getting the best, most effective treatment at every intersection with our system. So why are we talking about this? Well, more Americans now die from drug overdose than from the peak number of deaths from car accidents, the peak number of deaths from firearms, and the peak number of deaths from HIV/AIDS. In fact, more Americans have died from drug overdose than all deaths from HIV/AIDS in this country since the beginning of the HIV epidemic. So today, if today is like any other, 115 Americans will die from an opioid-related overdose. Across Massachusetts today, 6 people will die. And the thing that I hope to leave you with, one of the many reasons this is so tragic, is that these are preventable and treatable illnesses, and none of these deaths should be happening. We actually have treatment that treats the underlying disease that's driving the death, and then it's really an issue of not implementing that treatment, not making it available, that's driving the ongoing rate of death. When we look at what people are dying from, you can see that over the past 15 years, there's been a rising rate of any death-related or any opioid-related death. But in the past few years in particular, really beginning around 2013, the predominant thing that's killing people is fentanyl. So you may have heard about that in the news. Fentanyl is a highly potent synthetic opioid that's about 50 times more potent than heroin. We hear a lot about prescription opioids, and I'll talk about that, but when we think about what's killing people right now, it's really heroin and increasingly fentanyl. So why do we talk so much about prescribing? Well, if we look at the onset of the current crisis of opioid-related death, it correlates strongly with changes in prescribing practices. So you can see that the dotted line on top is illicit sales of prescription opioid pain relievers. So these are prescriptions from a prescriber. And you can see that beginning in the late 1990s, things began to change pretty dramatically. And our approach to pain management, our approach to prescribing changed, where we began prescribing at much higher rates in terms of opioid pain relievers. And I'm sure you've heard this story. This is what's in the press all the time. And in correlation with that, we saw a rising rate of death from prescription opioids and a rising rate of treatment admissions for opioid use disorder. So certainly the onset of the current crisis was strongly correlated with prescription opioids. But what started the epidemic and what's sustaining the epidemic are not the same, and that's something that we don't always talk about, particularly in sort of the press coverage of this. And actually, deaths from prescription opioids began decreasing around 2011. So you can see the blue line is deaths from prescription opioids, and you can see that it was increasing dramatically and then really peaked sort of 2011, and it's been declining ever since. And it's really been replaced entirely now with deaths due to heroin or illicit fentanyl. And so I think that gets at the complexity of the current crisis. There's a saying that for every complicated problem, there's a simple solution that's wrong. So the simple solution, I think, has been, well, let's just stop prescribing. If we just make it hard for people to get these medications, then they'll stop dying. But in fact, if the deaths are due to an untreated chronic illness, which is addiction, if you simply make it hard to access prescription painkillers, people aren't going to get well from their chronic disease. They're going to shift into whatever else is available, and it turns out heroin and fentanyl is increasingly available and increasingly potent and dangerous, and that's what we've seen. And so really the change in the drug supply has been incredibly rapid, where prior to 2013, we basically didn't see fentanyl in the illicit drug supply. It was all heroin. And beginning in 2013, there was this rapid change where now predominantly what people are buying, even if they think it's heroin, is almost entirely fentanyl. And because the potency is so variable, when someone's buying a substance and they have no idea what it is, they don't know if it's going to be a weak opioid, they don't know if it's going to be so strong that a few grains would be enough to kill them. And so there's this element of unpredictability that's entered into the supply. The common narrative of sort of the path to opioid use disorder over the past decade has been become almost a stereotype of someone exposed to a prescription opioid, whether for an actual prescription for pain or because of non-medical use of prescription opioids, and then a gradual transition from prescription opioid use to heroin use. And that certainly was true back in 2005. So this study was looking at the first opioid someone with opioid use disorder used as they report when they're entering into treatment. And so you can see in 2005, oxycodone and hydrocodone, two of the most commonly prescribed opioids, were by far the most common opioid that people were initiating their opioid use with. And yet in 2015, you see that those curves have shifted. And so the dark blue line is actually heroin. And so in 2015, more people entering into treatment reported that heroin was the first opioid they used than the different prescription opioids. And so again, if all we focus on is supply, if all we focus on is how easy or hard it is to get prescription opioids or heroin, we see this sort of whack-a-mole game where people shift to whatever is more available. And so what I hope to talk more about today is really the demand side of that equation. How do we treat people with the disease of addiction? We talk a lot about overdose death, and obviously death is the worst outcome that we want to prevent. But for every person who dies, many more people experience non-fatal and potentially catastrophic complications. So people who survive overdose are sometimes left with terrible complications. Young people who've essentially had strokes, people who lose limbs who have to get open heart surgery. There's many other medical complications that come from untreated opioid use disorder. And we've seen across the country this rising rate of hospitalizations for opioid-related causes and ED visits for opioid-related causes. And so the green line here is emergency room visits, and you can see the national average is 177 per 100,000 people. Massachusetts is actually 450, so we have the highest rate of emergency room visits for opioid-related causes of any place in the country. When we think about people who are sick enough to get to the intensive care unit, we've seen a rapid increase in people who survive an overdose on the streets, but they come in so sick they need to be in the intensive care. Now these are mostly young, otherwise healthy people, and so if they make it to the hospital, most people survive. The in-hospital mortality is only about 10%. But then of this very young population who survives, recovers, leaves the hospital, 25% are dead at a median follow-up of 31 months. So there are many more challenges that face that person when they walk out of the hospital doors than simply surviving their ICU stay or their overdose. So what can we do? Well, one thing is we can use science. We're sitting in a science museum today, and I always say the great thing about science is it's true whether you believe in it or not, and there's a lot of science about opioid use disorder. This is a wonderful report in the New England Journal of Medicine that was co-authored by the head of NIDA, our federal research organization around drug addiction, and the NIH. And they really wrote that when we look at the history of public health, when we look at other epidemics, whether it's influenza, which we heard there's a coming talk about, or HIV, it's really been science that has helped us get the breakthroughs, create the change that we need to save lives. And when we think about how we need to address the opioid use disorder crisis, really it will be no different, and science is every bit as important. But before we turn to the science, I think narrative is really powerful when you understand the experience of any chronic illness, but especially addiction. And this is an old quote from 1953 from William Burroughs' very famous sort of pseudo-memoir about his own struggles with heroin addiction. And he wrestles with the question that I think we still struggle with, the sort of why does this happen to some people and not others? And as Burroughs points out, no one would choose to develop addiction. So no little kid says, you know, when I grow up, I hope I'm addicted to heroin, and I suffer multiple overdoses, and I get hepatitis C, and I experience incarceration. No one would choose that, right? And yet we often hear this narrative that somehow people are choosing what's happening to them when we think about addiction. And in fact, 90% of Americans choose to expose themselves to highly addictive substances. I certainly have. I've had to make 3 cups of coffee today, had a glass of wine last night, so I've made a willful choice to expose myself to addictive substances. I imagine many of you in the audience have. And for some minority of us, we're vulnerable to developing the disease of substance use disorder. So 15% of Americans at some point in their life will meet criteria for substance use disorder. In some ways, it's interesting that not all of us do, since we're all exposed to many of these very potent substances. And as Burroughs described, he tried drugs out of curiosity, and whatever reason it is that people might start experimenting or be exposed to substances, he described sort of drifting along using until one day he wakes up in acute withdrawal and realizes that something is different. And I often hear this actually from young people in particular, where the first time they experience opioid withdrawal, they think they have the flu. They have no idea what's going on or what's changed. It's often a friend who explains to them, oh no, this is heroin withdrawal, or this is opioid withdrawal. And so what Burroughs describes is what we now understand as the natural history of opioid use disorder, where early on people use drugs to feel good. That sounds sort of simple, but we often don't talk about the fact that heroin makes people feel good. People would not use drugs if there weren't positive things that came out of it. And in fact, not everyone feels good when they're exposed to an opioid. So some people feel terrible. They feel nauseous and itchy and what we call dysphoric. They just feel sort of terrible and like they are having a really unpleasant experience. And those people are probably protected from developing an opioid use disorder. And then other people, you talk to them about the first time they were exposed to an opioid, and they describe it with almost magical terms, that it felt like falling in love. It felt like being wrapped in a warm hug or being in a warm bath. And I think those narratives really show sort of the genetic differences, the actual receptor differences in how people respond when exposed to these substances. But whatever reason that someone is first using an opioid, whether it's to manage pain or for escape or relief or simply for pleasure, what we see in someone who's vulnerable to developing opioid use disorder is this shift from using to feel good to needing to use to feel normal and then needing to use just to not feel sick. So sort of a shift from using to feel good to using to feel better. And And if you talk to someone with opioid use disorder, they're not like having fun and partying after many years. They literally don't feel normal. They can't function. They can't do the things that they need to do in the day without the substance in their body. And so put another way, from another person with lived experience, when you can stop, so early on, before you developed opioid use disorder, you don't really necessarily want to. You're not having negative consequences. There's nothing in your life that's saying, man, I really want to change this behavior. And then when you want to stop, when all of a sudden terrible consequences start happening, something has changed and you can't. And so we now understand addiction as this complex interplay between biology, so it's about 40 to 60% based on the genes you're born with, and then environmental exposure. And so that's very similar to other chronic illnesses. So diabetes, same stats, 50% nature, 50% nurture or environment. So with things like heart disease or diabetes, we think about diet, exercise, how stressful is your work, what sort of environmental things are you exposed to. And with addiction, environmental factors are absolutely important. So things like early adverse childhood experiences, co-occurring psychiatric illness, being around peers who use drugs, the age at which you're first exposed. But biology is crucial, so it is about 50% of the equation. And then obviously you have to actually be exposed to drugs or alcohol to develop a substance use disorder. So even someone with all those risk factors and with a strong genetic predisposition will not develop a substance use disorder unless they're exposed to the substance. And then we actually know that being exposed to the substances then further changes your biology. So it actually changes the structure and function of your brain. And that constellation of changes is what leads to the illness that we recognize as addiction. So we define addiction as a primary chronic brain disease that's characterized by compulsively using a substance despite harm. And there's a couple important points in there. So first, this is a chronic illness, so the goal is not cure, but rather to get people on treatment and in remission, and to minimize the number of relapses someone might experience. And it's fundamentally defined by an irrational behavior. And I think that's the thing that's so hard for people who care for someone with addiction, people who love someone with addiction, for the public and policymakers to understand. Because it's very easy to look at someone and throws back to the addiction and to say, why don't they just stop? Look at all these terrible things that are happening to them. They're having all these health complications. They've lost custody of their child. They've been incarcerated. Why don't they just stop doing this thing that's clearly causing them so much harm? And yet the fundamental hallmark of the illness is not being able to. So the hallmark of the illness is no matter bad things happening to you, you continue to compulsively want to use the substance. And so asking that person to sort of willfully stop would be the same as asking someone with another chronic illness to willfully create change in their body. And I'll show you some of the evidence we have for why those changes persist. It classically involves cycles of relapse and remission. Unfortunately, with addiction, we often think that when someone has a recurrence of symptoms, it's somehow a failure or a sign that they're not going to get well. It's not. It's the same as any other chronic illness. It just signifies to us that they need a change in their treatment plan. And we already touched on how highly genetic it is. And we can actually use functional imaging now to see in a very visual representation how similar addiction is to other chronic illnesses. So if you think about heart disease, we can use functional imaging, meaning we look at how well the heart muscle is pumping. And see on the far left, you see a healthy heart, the sort of upside down U, and the bright color throughout the heart muscle it signifies normal, healthy metabolism, so that all that heart muscle is working normally and able to pump. Next to it is the heart of someone who's had a large heart attack, and you can see there's an area of the heart that no longer is lighting up. So that is an area of scar tissue, so that part of the heart no longer works, and that leads to the chronic illness we recognize as congestive heart failure. Next to it, you see the brain, first of a healthy individual, where the top part of the brain, the frontal lobes, are lighting up bright yellow. The frontal lobes are the part of our brain that allow us to think about risk and benefit and delayed gratification and consequence, sort of the braking system of our brain. So we all have the gas pedal. We all have sort of deeper instincts to do things that feel good and that cause pleasure. But most of us have a very healthy braking system that can say, if I do that, it's going to lead to bad things happening in my life, or the benefit is not worth the risk, and sort of we make that sort of willful decision. This is the part of the brain that develops last. It takes until about age 26, which is why if you have teenagers in the audience, they sometimes seem to behave so irrationally. It's also why young people are more vulnerable to developing addiction if they start using substances at an early age. And so next to it, you see the brain of someone with substance use disorder, and you can see that those frontal lobes, the prefrontal cortex, is no longer lighting up, it's no longer metabolically active. And so you essentially get this imbalance where it's almost like you're driving a car, your foot's slammed down on the gas, and the brake is no longer working. So that's sort of what's happening in the brain of someone with active severe substance use disorder, is that reward circuitry, the sort of urge to do the thing that causes pleasure and relieves pain and makes you feel better, is in overdrive, and you have no ability to put the brakes on that and think, oh, wait a minute, that's going to cause me to have all these negative consequences. So asking that brain to sort of willfully decide to stop using substances would be like asking that heart to just pump harder. If the part of your organ that controls that function is damaged, you can't willfully make a decision no matter how much you want it. And so I think looking at the imaging can help us sometimes understand the behavior that appears like it's a choice or like it's willful, when really it's a symptom of an underlying chronic illness. The great news with substance use disorder is that recovery happens, and we can visualize that too. So we're now looking at a different part of the brain. We're looking at dopamine transporters. And again, on the left, the sort of bright red is the most active, and you can see a healthy brain. In the middle, you see the brain of someone, in this case, with methamphetamine use disorder. And then next to it, you see the brain of someone in recovery. And you can see that with recovery, the brain normalizes in this case. But in this study, it took 14 months of treatment and recovery for the brain to begin to look normal. And the brain in the middle is actually a person who'd been sober for a month. So if you think about our treatment system and the way many of us think about treatment, that you go to a 30-day program or you go to a few weeks of a detox program and then you're fixed, that brain in the middle is every bit as sick as the brain of someone who's still actively struggling. And it takes months and years before those changes begin to normalize and before the likelihood of relapse goes down. And so we've taken an illness that everything we understand about it from science is that this is a chronic disease that is absolutely treatable, that takes months and years of ongoing treatment. And yet we've developed an entire treatment system that approaches it like it's an acute fixable problem. And so really, we're setting patients up to fail. We're sending them to treatments that there's no evidence to support and that we know are not going to lead to long-lasting change. And then when they don't change, we blame them. We say it's their fault, that they've somehow failed, or they didn't try hard enough, or they weren't ready, or something else like that. But if we start to think about addiction as a chronic illness, treatment outcomes are as good as they are for other chronic diseases. So if we compare it to hypertension or high blood pressure, you can see this is a graph of sort of response to treatment, and we would expect that without treatment, people with high blood pressure would have high blood pressure. With treatment, a majority of people respond, and if you all of a sudden stop that treatment, many people are going to have a rebound in their blood pressure. We see the same outcomes with addiction treatment. So of course, people's addiction is severe without treatment. With good treatment, at the end of 1 year, upwards of 60% of people will be in remission, and if you stop treatment prematurely, a significant number of people are going to have a recurrence of their active disease. So what is effective treatment? When we talk about opioid use disorder in particular, it's generally a combination of some of these three buckets. So medication treatment or pharmacotherapy is incredibly effective for opioid use disorder, and there are 3 types of medication we have available in this country. Psychosocial interventions, which we think of as sort of counseling or therapy. Another really important piece, although it's worth noting that the types of psychosocial interventions that are effective in early recovery from substance use disorder are not what we often think of when we think of therapies. It's not lying on the couch talking about your childhood or something like that. It's very skills-based, so it's either focused on how do you develop the skills to sort of prevent a recurrence from happening, so identifying situations that would put you at risk, coming up with new skills to manage high-risk situations or triggers, separating sort of thoughts from behaviors, that just because you have a craving to use drugs doesn't mean it has to lead to a behavior. Or they're motivational based, so they're around resolving the ambivalence people have around giving up drug use or engaging in treatment. And that's an important piece because I think we don't talk enough about ambivalence. Ambivalence is a hallmark of any sort of behavior change, but it's really important when we think about addiction. So what I mean by that is that people want 2 things that seem very opposite at the same moment. So if you think about creating any sort of change in your life, many of us want the benefits that come from going to the gym every day, and at the same time, we don't want to get up at 5 in the morning to go to the gym every day. So we can hold both those things in our head at the same time. You can both want one thing and yet not want the thing that it's going to take to get there. And so for someone with active substance use disorder, they may want to stop using drugs because of all the negative things that are happening in their life, and at the same time, they want to be able to continue to use drugs or alcohol. And both those things can be true at the same time. We often interpret that as the person's lying, so I often hear doctors say, my patient lied to me. He said he wanted to stop drinking and then he went out and drank. It's like, no, he wasn't lying. He really wanted to stop drinking, and at the same time, he wanted to be able to keep drinking, and both those 2 things can be true. And part of the work of motivational work is really resolving that ambivalence and figuring out what in that person's life might get better if they create change. It really doesn't matter why I might want someone to make changes in their life. The only thing that matters is what's going to get better in that person's life. And if nothing is going to get better from stopping using heroin in that person's life, it's actually hard to make a case for why they should stop using heroin, right? But we need to figure out what's going to get better in their life. How can we help them live a better life, reach whatever goals that person has? And then the other piece is around recovery support. So that sort of broad term, traditionally we've often thought of that in terms of mutual help organizations, which are groups like Alcoholics Anonymous or Narcotics Anonymous, and that's a great example of what recovery support can look like. But recovery support can come in many varieties. So there's other types of mutual help meetings. There's something called Smart Recovery, which we have meetings here at MGH. And then importantly, recovery coaches, which we're using across our system, which are people with lived experience. They're people in recovery themselves who really know what it's like to walk in the shoes of someone who's trying to engage in treatment and get well. And this is really the piece that's about building up sort of the fabric of someone's life and helping support what's really hard, which is managing a chronic illness. And that's hard if you have diabetes, that's hard if you have breast cancer, and there's a whole lot of stuff that happens outside of the doctor's office. And so some people find recovery support in exercise or in their job or their family or their community or their church. So it doesn't necessarily have to be sort of a traditional thing that we think of. And not everyone needs all three of these. So some people need one of these, some people need all three, some people need two. The important thing is what's going to help that individual person get well. So I'm an internist, I should have said that. I'm an internist and also an addiction medicine doc, so I practice both primary care and addiction medicine. And so I really think of addiction as very similar to diabetes or HIV, where my goal is not to cure someone, my goal is to prevent negative consequences from untreated disease and to help them live the best life and the best health they can. And while we have tons of science showing us what types of treatment work and what sort of targets we should be aiming for. So in diabetes, we think about certain blood sugar targets, and substance use disorder care, obviously we think about trying to help someone not use drugs anymore. But we then individualize that treatment to the person in front of us. So I may see a patient in clinic who I really think would benefit from insulin. Their blood sugar is incredibly high, and if that person tells me, you know, I'm terrified of needles, there's no way I would ever take insulin, but I'd be willing to try another medication, I would not offer them an oral medication because I think insulin is better, right? I would meet the person where they are and I would continue to work with them towards health. And yet, unfortunately, in addiction treatment, often things are made very black and white or all or nothing. Sort of, you take this or you don't. And if you don't want every single component that comes along with this package, then you don't get anything. And again, I'm going to blame you. I'm going to say that you weren't ready or you weren't willing to sort of comply with treatment. And so if we shift instead to really individualizing the plan to the person, then our outcomes are much better. And then just like diabetes care or HIV care, medication generally includes some combination of medications, lifestyle change, behavior support. It's really hard to create change in your life, and then ongoing monitoring. So we wouldn't treat someone with insulin for a month and then discharge them with no medication and expect them to stay well. We're going to continue to see someone, and we're going to vary the intensity of how frequently we see them depending on how well they do. The other thing I think we can learn from chronic illnesses, particularly is relevant for HIV. So if you think about HIV, we take a disease that at one point was a fatal diagnosis and an incredibly stigmatized diagnosis. Don't forget, HIV was called the gay plague when it first was discovered, and has now really transitioned into an illness that for most people can be managed with one pill a day and treated in primary care as a chronic disease that people live with, they don't die from. And there's a lot of lessons from how we got there, and this is sort of an equation people have proposed for, actually, some people predict that we may see an end to HIV in our era. And this idea of testing more, meaning identifying people early, so not waiting until someone is in the intensive care unit with an overdose, but rather identifying them early when we know that treatment is more effective. Getting people aggressively started on treatment. So again, not waiting until people hit bottom. We don't wait with HIV until someone has, you know, an opportunistic infection to start treatment. We want to start treatment as soon as possible and keep people on treatment. And then helping folks who are at risk stay safe. And so in addiction, we think about other ways of keeping people safe. So preventing them from getting infections, from sharing needles, preventing them from having overdoses, so all the many consequences and harm that can come as people are on their journey. And so I think that sort of combination of facts can be as relevant for addiction as it is for HIV. But the other thing we've learned from HIV is that medication is incredibly life-saving. So if we think about the death toll from the HIV/AIDS epidemic, it basically continued to skyrocket until we discovered life-saving effective medication. So in blue is deaths from HIV/AIDS, and then you can see that there's this junction where all of a sudden we discover our first antiretroviral therapy. And as medications came out and as medications were discovered, we saw this plummeting rate of death. And with HIV, that took biomedical breakthrough. We needed scientists to figure out what these new medications were, we needed companies to make them, and we had to wait for that to happen. And the great thing with addiction is actually we have very effective medications, and we don't need the same type of biomedical breakthrough. These medications are life-saving and are incredibly well supported by evidence. So the image on the left is data from Baltimore, Maryland, where the red line is death from heroin overdose, and the green dashed line is access to a medication called Buprenorphine. The blue line is access to a medication called Methadone. And as access to those medications increased, they saw heroin overdose deaths decrease by 50%. The graph on the right is actually out of the country of France, where any doctor can prescribe buprenorphine. Here in the US, we require certain additional training and licensing requirements, but in France, any doctor can prescribe it. And they were able to treat 90,000 patients in less than a decade, and they saw an 80% reduction in heroin overdose death rates across the country. So that same type of death response rate we saw with HIV is possible with medications for opioid use disorder as well. So that's why I'm going to talk a little bit more about medication treatments, because when we think about how to keep people alive, medications are a crucial component. So the three medications we have in this country are methadone, buprenorphine, and naltrexone. And so just a really quick lesson about pharmacology. So methadone you'll hear called a full opioid agonist, which means that it sticks to the opioid receptor in the brain, and the higher a dose of the medication a person has, the more effect they get. So it can be very effective. The idea is that it's very long-acting and it has a very slow onset of action, and the goal is to get people back to feeling normal. So if you think again about the insulin analogy, many people take a long-acting insulin, and the point of that is to sort of level out their insulin levels throughout the day for someone whose body is no longer producing insulin at a normal rate. And so methadone is very similar to that. The downside of methadone is because it's a full agonist, at very high doses people can get side effects like sedation or sleepiness, and people can overdose on it if they're at a very high dose. Buprenorphine, the middle medication, is what's called a partial agonist, and what that means is it sticks to the same receptor, but it has what's called a ceiling effect, which basically means that the curve flattens out. You can see at a maximum dose, even if you took 20 more tablets, you wouldn't get any more effect from it. So that means it has fewer side effects, and it's basically impossible to overdose on buprenorphine. So it's very safe to take in an outpatient sort of office-based setting. And then the third medication is a pure blocker. So it just sticks to the receptors and acts almost like a security guard. It prevents an opioid from being able to have an effect at that receptor. And so the goal of the top two medications of opioid agonist therapy is that you basically get people back to normal. So if you think about that sort of initial cycle I showed you where people go from feeling normal to good, and then there's a shift where people are using just to feel normal again. For someone with severe long-standing opioid use disorder, they may never feel normal without some stable level of opioid effect. And so our goal is to bring them back to normal. So again, it's very similar to if you think about other endocrine problems. So I don't know if you know folks who have underactive thyroid or hypothyroidism. We give them a chemically similar compound, basically synthetic thyroid hormone, to get them back to a normal level of functioning so that they feel normal. We do the same thing with insulin. We do the same thing for people with low testosterone levels or people who have low steroid levels in their blood. So this idea of sort of using a chemically similar medication to allow someone to feel normal and function normally. And so the goal of medications for addiction treatment, first are to relieve withdrawal symptoms. Withdrawal from opioid use disorder is incredibly painful, and although the traditional teaching has always been that you can't die from opioid withdrawal, first of all, you feel like you're going to die. And second of all, increasingly we are seeing deaths mostly in jails across the country because jails don't offer any treatment for opioid use disorder. And so people die from untreated opioid withdrawal, mostly from dehydration. But so the first goal is you want someone to be comfortable, you want them not to have withdrawal symptoms. And then the second goal is to block the effects of other opioids. So the other thing about those medications is that when they're in your body, if you use another opioid, so if you're in a situation where you're tempted to use and you do, you don't actually feel the effects of the drug. And so over time, patients will say, you know, I just know it's not worth it. Like maybe I was tempted because I was around an old friend, but I took my medication today and it would be a waste of money to use, right? I know that I wouldn't feel anything, and so that's really effective. And then fundamentally, addiction, one of the hallmarks is about craving, meaning a strong psychological urge to want to use. And so the top two medications in particular, methadone and buprenorphine, reduce that craving by, again, allowing someone to sort of feel normal. And then over time, sort of over 6, 12 months and longer, the goal is to restore the normal functioning of the reward pathway in the brain. So to help people sort of reset their normal tone around reward behavior. So they start finding things like relationships and exercise and food, the stuff that for us releases a dopamine level that feels rewarding. Well, that compared to sort of the reward of some substances, over time is not as rewarding as someone who's got active severe addiction. And so one of the goals of long-term treatment is to restore that sort of normal, people call it the normal hedonic tone, meaning sort of the normal amounts of pleasure and reward in response to things in our life. So what about medications just to detox people, or medications to manage withdrawal? So detox alone, or sort of medical management of withdrawal, is not effective for opioid use disorder. There's never been a study to show that going to detox is effective to manage opioid use disorder. Now that often comes as a surprise because we continue to hear people talk about detox all the time as if that's a useful intervention. This is one of many studies. This was done out of Hopkins where they looked at an inpatient detox, and then they asked people after detox if they had gone back to using opioids. And at the end of 1 month, almost 90% of people had relapsed, had gone back to using opioids. And that's what we see traditionally with detox. Worst of all, though, is that people who detox have their opioid tolerance removed, meaning that they're not used to the same amount of an opioid. So then that 90% of people who've gone back to using at the end of 1 month, their risk of dying from an overdose has just increased dramatically. And so not only is it not helpful in terms of long-term outcomes, but it's potentially very risky because people's risk of death has just increased. So what is effective treatment? What if I told you there's one treatment that at the end of 1 year, 75% of people were in remission and no one had died, compared to another treatment where at the end of 1 year, no one was in remission and 20% of people were dead? I would think we'd all be referring people to treatment A, right? We wouldn't continue to refer people to treatment B. But this was actually a study that was done in 2003. This was done in Sweden, where they took people with opioid use disorder and they randomly assigned them to either a placebo medication or buprenorphine, that partial agonist medication I mentioned, coupled with very intensive psychosocial counseling. So twice a week counseling, lots of follow-up. And in the group that got the active medication, 75% were in remission at the end of 1 year and no one died. And in the got just detox plus counseling and no medication, 20% were dead and 100% had relapsed. So really dramatic differences between these two strategies. The data supporting medication for addiction treatment with opioid use disorder is incredibly robust. People looked at lots of different things. This was a study in JAMA, another leading medical journal, that looked at, well, maybe we just need to do a slower detox. Maybe it's just that short detoxes don't work. And so they actually did a 180-day-long detox using methadone with psychosocial services compared to staying on methadone and getting those services. And you can see that the solid line is the group that got the slow detox. And you can see that pretty quickly, right as the medication starts being detoxed, people start falling out of care. And there's dramatic differences between those two arms. Whereas the group that's kept on the medication, about 80% of people stay in care until the medication stops and then predictably see that fall off. We also know that methadone treatment compared to non-medication types of treatment is much more effective at reducing opioid use. So this is what's called a meta-analysis, meaning that scientists look at as a whole host of studies, often many studies that allows them to look at a much larger population, and they summarize all the findings. And they found that opioid use in people on methadone was 44% lower than people who were in other types of treatment. The other thing we know is that having to wait for treatment is deadly. So I'm sure you've heard of people who have to wait for weeks or sometimes even months to get into treatment. And I think we all recognize the frustration in that, but what we often don't recognize is that you're 10 times more likely to die while you're waiting for treatment than if you get accepted into treatment. This is a study in Norway looking at people on a waiting list to get into methadone versus those who are accepted, and again found this dramatic difference between the death rate of those who get into care versus those who don't. And then the other thing is that when medication stops prematurely, people die. And so simply stopping the medication before someone is ready is not an effective strategy. This, again, was a very large study. Looked at almost 16,000 patients who've been treated on buprenorphine for an average of somewhere between 1 and 4.5 years, and found that while people were on the medication, their overdose rate was 1.4 per 1,000 person years. And if they stopped the medication, their overdose rate more than tripled. So again, being on medication, life-saving. And also, being on medication reduces likelihood of relapse and of cost. So this is a study across Massachusetts looking at Medicaid members in Massachusetts, and found that people on medication treatment were 50% less likely to have a relapse, and overall cost health insurance about $150 to $220 less per member per month. And then more recently, there was a head-to-head comparison between buprenorphine and the blocker medication I mentioned, naltrexone. So naltrexone is a wonderful idea. I think it sounds really appealing, the idea that you can just take something that lets you not feel the effects of the substance, and so prevents you from being able to use opioids. And for people who have less severe opioid use disorder, or people who, as a relapse prevention tool, that can be very powerful, because over time, what patients will say is that they just sort of stop. They know they can't use, and so over time they stop thinking about it so much. But for all comers, if you take all people with opioid use disorder, again, because of those changes and how sort of the normal opioid effect works, so that shift from sort of normal to not feeling normal about the medication, medications like buprenorphine and methadone seem to be much more effective. So this was our first sort of head-to-head study that looked at people who were put on buprenorphine versus those who were on naltrexone, and found that people had fewer relapses, fewer days of use on the buprenorphine medication than the naltrexone. So I think this just points out that we need to be thoughtful about who we assign to what type of treatment. And the most important thing at the center of that is what type of treatment the person wants. So not sort of having one-size-fits-all approaches, but rather tailoring treatment to the individual human. And yet, despite all the evidence I've shown you, what actually happens in the treatment world and what we just talked about often don't look that similar. So why is that? Why do we continue to hear people talk about short-term detox as a solution? Or why are there still wait lists out there? Why are people dying while they wait for treatment? And I think a lot of it really gets at stigma, and I think that is a huge component of what needs to change as we think about solutions. And as a country, we've criminalized drug use for 100 years. We've thought of this as an issue of the criminal justice system, an issue of bad behavior. And so many people and many sort of policies over history have really designed systems where we sort of make it really hard on people, and we expect them to just pull themselves up by their bootstraps. And policymakers and even some treatment providers continue to talk about detox as an effective strategy, despite the fact that there's no evidence to show that that actually helps people stay off drugs. So what is clear, this is from the Surgeon General's report in 2016. This is a landmark report, first ever Surgeon General's report about alcohol, drugs, and health. So sort of similar to the first ever Surgeon General's report about tobacco. And as Surgeon General at that point, Vivek Murthy, points out, the science is clear. There's really no debate in the scientific community, and yet there continues to be very strong opinions and very strong sort of belief about the use of medications. And you'll hear people say things like, why aren't you just addicting that person to methadone, and isn't that person just addicted to buprenorphine, or you're just replacing one drug with another. But if you get back to what that definition of addiction is, so compulsively using a drug despite bad things happening to you, taking a medication every day that a doctor prescribes to you that allows you to feel normal, to function, to have relationships, to not die, to not get infections, does not meet the criteria of addiction. That meets the criteria of how we manage many chronic diseases. So addiction, we're simply having to take a medication every day to stay healthy, then any of you who take a chronic medication for your blood pressure or your cholesterol would be addicted. But you're not, of course. You're managing your health and managing your chronic illness. And so I think shifting that confusion, particularly in the public and the policymakers where we hear it most often, is really important. Other countries, I think, get this more than we do. This is the World Health Organization's report from 2009. It's almost 10 years old now, where they recommend that of all treatments, ongoing medication treatment with methadone or buprenorphine is the most effective, and that while psychosocial services or counseling should be offered to every single person, if a person doesn't want the counseling piece, they shouldn't be denied life-saving medication, which isn't always how we approach things here in this country. And that treatment has to be long-term, and that gets back to this chronic illness thing. Not infrequently, I find patients who are sort of either explicitly or implicitly given the message from people in their life that, that they should come off their treatment, that it's sort of been long enough. And yet, with any other chronic illness, we would really support and encourage and congratulate people from having the commitment to be able to really stay engaged in care and continue managing their illness. And so treatment for addiction is no different, that for many people it has to be over years, and that that's a good thing, that the goal is recovery and quality of life and health. And the other thing is that long-term outcomes are incredibly positive. So this is one of the longest-term studies we have of buprenorphine, which was a multi-site study. One of the sites is out of McLean, but they followed people for 42 months. And they found at the end of 42 months, only 8% of people still met criteria for opioid use disorder. So 92% of people were in remission. Those are not statistics we get with other chronic illness management. And I think we don't talk about this enough. A lot of people have this sense that opioid use disorder is not a treatable condition or that most people don't get better. But with good treatment, the majority of people will achieve remission. And so really having a hopeful feeling when we think about this illness, and rather than blaming the disease or blaming the person, the thing that has been failing is our treatment system. The reason people don't get well is because we don't give them effective treatment, not because the disease is not treatable. And the other thing is that treatment takes time. This was a study that followed people for 60 months that looked at ongoing opioid use and the different types of treatment. And the first thing you notice is the difference between medication treatments and no medication treatments. So although all people get better over time, the darker two lines in the bottom are people on one of the two medications, and the lighter line is no medication. But also that early on, people are continuing to use opioids. So this is number of days of use in the past month. And you can see in the first few months, people are using opioids 5 or so days out of the month. Now that's not 30 days out of the month, so that's actual incredible progress. But again, in addiction treatment, we often make things very black or white. Are you sober or not sober? Is your toxicology screen positive or negative? Rather than thinking about sort of overall progress. Where with other diseases, like diabetes, we wouldn't expect that someone goes from blood sugar of 500 every day to a blood sugar less than 100 over 1 month of treatment. We sort of work our way towards progress. And so that idea of really sticking with people, thinking about this as a chronic illness and hanging in, ultimately people do continue to get well. Unfortunately, in many treatment programs, we kick people out of care when they have a relapse. And so early on, when people are actually making improvements, but they haven't yet gotten to total remission, they're getting kicked out of treatment. The other thing we know is that treatment can be effectively delivered in primary care. And so as a primary care doc, I think this is a really important message. This is what we do in primary care. We manage complex chronic illnesses that are and that involve sort of biology and social circumstance and behavior change. And we provide counseling, and we provide medication, and we monitor people over the long haul. This is our bread and butter, and yet unfortunately addiction has been carved out of that for a very long time. And so I think treatment outcomes are good when it happens in primary care. Patients want to be able to get this treatment in primary care. They don't want to have to go to a specialty place. And if we think about the need across the country, there's no way there will be enough addiction specialists in the coming decade to serve the millions of people with opioid use disorder. But we have an incredibly robust system of primary care doctors. So if primary care doctors could deliver this treatment, we would actually be able to meet the needs. The other thing we've learned is that hospitals have an opportunity to initiate treatment. And this is, may sound not that radical, but it's actually radically different than how we've historically thought about addiction treatment. So again, the whole treatment system generally, addiction has been carved out from the rest of the medical system, and we make it really, really hard to get treatment. You have to find a program, you have to call, you have to schedule an appointment, you often have to wait for a few weeks, you have to show up on time, you have to go through a whole intake process, and then maybe you'll get treatment after that whole long journey. As one of my young patients told me, he was able to do that, to find a program to call, stay on the phone, schedule an appointment, remember when the appointment was, wait until the appointment, show up on time, talk to a counselor for an hour. Like, he'd be doing pretty good. He probably wouldn't need the treatment. But he's shooting heroin 3 times a day. Like, he's not able to do those things. And so we built a system that really is not accessible to the people who need it most. And so studies have begun to look at what would it look like if we actually made treatment the easy choice. What if we brought treatment into the health system so that at any point when someone's coming in contact with the health system, they have access to immediate treatment. And so this has been studied in a number of studies. So one study looked at taking all comers to the medical services, not necessarily people who wanted to get help or get treatment, and starting them on medication treatment in the hospital. And actually, if you do that, 82% of people will present for follow-up. It's incredibly high retention rates. They then did a randomized control study looking at comparing detox and sort of direct referral. So detoxing someone in the hospital and saying, you have an appointment next Tuesday in this Buprenorphine clinic versus starting the medication and continuing and linking people directly into care. The folks that were linked with the medication, 72% entered into treatment versus only 12% if they were detox. So that sort of medication bridge, allowing people to feel normal so they can get to that appointment, is incredibly crucial. A group at Yale took this a step further and said, well, what if we do this in the emergency room? So they actually took folks who came into the emergency room and they did a randomized controlled trial where they randomly assigned people to either get buprenorphine started in the ED or referral to treatment. And the group that started buprenorphine in the ED, almost 80% were engaged in treatment a month later versus about a third if they had to wait 3 days before they could get the medication. We also know that treatment can be done effectively in correctional facilities, so in jails and prisons. This is a review of 21 studies across the globe. Many other countries do offer treatment in prisons. We generally don't. Rhode Island is the first state in the country, actually, to begin offering treatment in prisons. And they found that treatment with medication during incarceration, not surprisingly, increases the likelihood of people engaging in treatment when they leave. It reduces ongoing heroin use and reduces during incarceration use as well. So people do find ways to get drugs while they're incarcerated. We have a mobile van called the Care Zone van through the Craft Center where we're actually going out and delivering treatment on the streets, which is really exciting. This is also a model that's been shown to increase engagement with more vulnerable populations. So compared to fixed site treatment, expecting people to come to you, if you bring treatment to people, you reach a more marginalized and a sicker group. Despite everything I've shown you about the powerful effect of these medications, if you look at physicians across the country, this is in 2015, only 2% actually have done the training to be able to prescribe the medication buprenorphine. So the vast majority of physicians have not, and 50% of US counties don't have a simple prescriber. So we're in the midst of a crisis. We have medication that reduces the death rate by somewhere between 50 and 80%, and yet most doctors haven't been trained and aren't able to offer it. In even areas that actually have really good access, most doctors don't prescribe very often or at all. So about half of people who get the training never actually go on to prescribe. And here in Massachusetts, actually the median monthly patient census is only 22. So for folks who sort of listen to the news around this, Congress passed an act called the Comprehensive Addiction Recovery Act that allowed doctors to increase their caps to 275 patients, but most doctors are nowhere close to that. So this is not an issue of simply lifting the caps of a few doctors, but rather how do we make sure this treatment is accessible in doctors' offices across the country. So we, starting in 2014, launched our MGH Substance Use Disorder Initiative, which essentially was our effort to take all the evidence I've just shown you and think about what would it look like if we began to redesign our own system so that we were applying that best evidence in our healthcare system, from our emergency room to our inpatient hospital setting to our primary care practices. And so we developed a number of different interventions. We started an inpatient addiction consult team, which is a specialty team that sees people in the hospital with substance use disorder. So in the same way, if you have a heart attack, you probably want to see a team of cardiologists when you come into the hospital. Well, if you have a life-threatening overdose, you really should see a team of experts in addiction medicine when you get hospitalized. And so now you can across every floor in the hospital. We started what we call our bridge clinic, which essentially is an urgent care sort of transitional clinic model where patients can just show up. About 50% of our visits aren't scheduled ahead of time. People can walk in. They don't have to want to stop using or want to engage in treatment to come. They can come get coffee. We have snacks. We have warm clothes. We have a very welcoming and kind staff. And the idea is that if we can begin to engage with people, begin to treat them with kindness, begin to form relationships, and offer them treatment with no restrictions, no sort of barriers to, or hurdles or appointments you have to keep, but just show up, that people who are the most sick will actually engage in care. In our outpatient setting, we began integrating addiction treatment across our primary care practices by creating teams of champions at each of our primary care practices. And then importantly, we hired recovery coaches. We have 10 recovery coaching positions across the MGH. And these are people with lived experience. They've literally walked in the shoes of the people that we're caring for. And they provide just invaluable support, motivation, hope, and very concrete sort of navigation of a really complex system. So we call them our human glue, but they're a really invaluable piece of the model. We've done, at this point, about 4,500 consults across the hospital, and we found that people who are seen by the addiction consult team are more likely to stay sober after they leave the hospital. They're less likely to come back to the hospital, they get readmitted, and they have lower addiction severity after they leave. In our bridge clinic, we've cared for about 600 patients. Our clinic is a transitional model, so the idea is to stabilize people and ultimately connect them into community-based services. So people stay with us about 2.5 months. And as I mentioned, 50% of the visits aren't scheduled ahead of time, so it's really important to have that very flexible care model. In our primary care practices, we have 10 coaches who've had almost 12,000 contacts with about 1,200 patients. And they provide a ton of support for patients who really need that human connection. We found that patients who are linked to a recovery coach have 25% fewer inpatient admissions and 44% more outpatient appointments. So they're more likely to see their primary care doctor, to see their therapist, and much less likely to come back to the hospital. We've increased access to that life-saving medication, Buprenorphine. So across our 3 health centers alone, we have almost 40 doctors who are caring for about 550 patients on that medication. And we've got these robust teams that come together to meet and talk about cases. We're just finishing up our Get Waivered month in the emergency department. So across the country, fewer than 1% of emergency doctors have been waivered to prescribe buprenorphine. Last I checked, 89% of our doctors have been waivered to prescribe buprenorphine. So we've done this wonderful campaign to get doctors in the emergency room waivered so that we can really offer treatment in the moment that people come in after an overdose in desperation and then link them into care. In April, so very soon, we're opening what we're calling the Hope Clinic, which is our family clinic. So the clinic will be for pregnant women and partners, and then parenting families. So the idea is that we know that pregnancy is this incredibly vulnerable, but also very motivating time for women and for families. And so offering integrated sort of one-stop shop care for pregnant women, but then continuing that for 2 years. Because one thing we've seen across the state is actually the risk of dying from an overdose increases dramatically 6 months postpartum. And what we hear is that during pregnancy people get a lot of support, and then after delivery the bottom just falls out. If someone's a new parent, they're dealing with all the stresses that go along with that, and all of their supports around their addiction have sort of dissipated. And so really extending that, having this integrated home for families for 2 years is the next piece of our model. We're also starting an addiction medicine fellowship. We have 2 fellows starting in July. Part of our hope is to train up future specialists and leaders across the institution. And then one thing just to end with is that the first step to treatment or recovery is being alive. So we can't talk about addiction without talking about how to keep people safe. And again, today 6 people will die, and we have ways to keep people safe even when they're continuing to use drugs. And so one of those is the overdose reversal medication naloxone. I have some in my backpack. Hopefully, if you are in the area, you're carrying some. Certainly, if you know someone or love someone, you should have naloxone at home. This is a nasal spray that immediately reverses an overdose, so we can all save a life. And making sure we're keeping people alive until they engage in care is crucial. And then I'm going to end with this quote. I didn't get to talk about language. Language is a passion of mine. The terms we use around substance use disorder that are very different than other medical illnesses. But one term I really hate is enabler. Often we talk about people who are being kind or compassionate to someone with addiction as being an enabler. And so I like to flip that on its head and think about how can we enable people to stay alive? How can we treat people with dignity, enable them not to overdose, not to get hepatitis C? So I'm very proud to call myself an enabler. And I would love to take questions from the audience.